It wasn't really a conscious decision. I originally worked as a general practitioner and I saw lots of female patients, I think because they naturally wanted to see a female general practitioner. Initially, I provided mainly contraception, and it's kind of logical, I think, to move into menopause management, as that's also clearly to do with hormones, to do with a hormone deficiency. And I've had an interesting career. I've seen menopause go through peaks and troughs, and I've never really seen that happen with any other specialty. So in 1993, we were giving most women HRT for a variety of reasons. And then, of course, in 2002, we had the Women's Health Initiative published, and that was very damaging. Women came off HRT, GPs stopped prescribing it, and it took a long time for things to recover. And then in 2015, we had the publication of the NICE guideline that was very clear, very positive. And at that point, I think we started to provide individualised care, ensuring that women were listened to, which hadn't happened for a long time, and that they were prescribed HRT if that was the right thing for them. And I think in a way, it's great that there's been a lot of publicity about menopause, but it's not a cure-all. And I think those consultations with menopausal women are an opportunity for them to take stock, to look at how they're managing their life in general, what they're eating, what they're doing. It's a time often when women's children have left home and they might be left together with their husband, which hasn't happened for a long time. So it's a time for them to focus on their own relationship. There's no reason why older women shouldn't have sex, and that's partly why I developed the interest in urogenital atrophy, because if you ask women about symptoms such as vaginal dryness, itching, burning, pain during sex, many of them will actually say, yes, that is a problem, but without the support and being asked, then they're very reluctant to ask for help, and they assume that that's a natural part of aging, which it doesn't have to be. I think certainly in the UK, there's been a lot of celebrity interest, media interest, social media interest, and a lot of traffic, which has pros and cons. I deal with many women who have experienced hormonally dependent cancers, and these are relatively young women who not always excluded from hormone replacement therapy, but in many cases, they are either unable to take HRT or reluctant to do so for obvious reasons. So I kind of feel it's better really to perhaps take a little bit of a step back at this point to ensure that women are not using excessive amounts of hormone to fix everything that might be wrong, because that's never going to work, and that we should focus also on women who can't have hormone replacement therapy and to think about alternative methods of managing menopause. And there are many new things coming to market, new non-hormonal drugs to manage hot flushes and night sweats, difficulty sleeping, and also non-hormonal treatments for urogenital atrophy such as laser. I think the mood disturbances are less well recognised. Anxiety, loss of confidence, brain fog, loss of libido, generalised aching, just that feeling old. Now, there'll be an element as you age of your body deteriorating a little bit, but I think hormones do play an important part in muscle mass, in tissue quality. And I genuinely believe that patients will associate hot flushes and night sweats, menstrual disturbances, difficulty sleeping with menopause. But if they suddenly become extremely anxious, unable to cope, unable to function in the workplace, then they're less likely to associate that with menopause. So what I've just described really are short-term symptoms, although they can last many years. Intermediate consequences of hormone deficiency include urogenital atrophy, which doesn't just affect the vagina, it affects the bladder, and it can lead to recurrent urinary tract infections. And then we have the longer term consequences associated with hormone deficiency, a reduction in bone mass. Women will lose approximately 1% of their bone mass per year when they're estrogen deficient as a result of the menopause, and they will also have an increase in cardiovascular risk. And as I said, it's not just about focusing on hormones. I think a menopause consultation is an opportunity to check blood pressure. We know that 50% of women roughly have high blood pressure by the age of 50. And if we treat that, then we reduce their overall cardiovascular risk. And if we talk about general risk reduction, if the patient is overweight, for example, to support her to lose weight will reduce her risk of becoming type 2 diabetic, with all the consequences that come with that. So I really do think this is a time in a woman's life when we can make a huge difference with the right information delivered to the patient. So the information is crucial. And I think the social media input is helpful in a way because it raises the profile of menopause, but it's very difficult to know what information women are accessing. So I think the Fast Facts booklet for women was an extremely valuable resource because it was evidence-based. We updated it after 3 years, and from my point of view, I know that when I provide my patients with that resource, that they are being provided with the right information. Yes, so about 80% of women, roughly, will suffer the consequences of lack of estrogen on tissue quality in the vagina, but also the vulva, which is the outside, as I said, the bladder, and also the urethra. In a healthy vagina, which has adequate estrogenization of the tissue, then the superficial layer of cells is thick, and it sheds roughly every 4 hours. And those cells are full of glycogen, which support lactobacilli, which are healthy vaginal bacteria. So we all have lots of different organisms in our vaginas. But if the patient has lack of estrogen, and that means that the superficial cells are reduced and there's less glycogen, then there are less healthy bacteria, and the other bacteria start to overgrow. And that includes things like E. coli. In this condition, the urethra becomes much more prominent. It's short in women anyway. And the natural course is for these non-healthy bacteria to ascend the urethra into the bladder and cause recurrent urinary tract infections, which can be very debilitating. Lead to treatment with long-term antibiotics, difficulty functioning in the workplace. And I think, we have a workforce that's made up of a huge number of women who may be affected by lack of estrogen. And then, as I said before, in addition, we see women experiencing vaginal dryness, itching, burning. The folds in the vagina are lost, so the capacity to stretch is reduced. It becomes shorter. You can get loss of the small lips, fusion of the lips over the clitoris, so sex becomes less pleasurable and ultimately, for some women, completely impossible. Now, providing women with the information at the outset enables them to have treatment earlier on, and that reduces the risk of these potentially irreversible changes in tissue quality. I think there are lots of resources available for women. I think it's important that women access the right resource to inform them about the best way of managing their menopause. And I think that that's much better provided early on. This is a journey. Women are going to spend approximately a third of their lives post-menopause. So we have reproductive life, we have the menopause transition when their hormones are all over the place, really, relatively speaking, and then post-menopause when hormone levels are low. I'm chairman-elect for the British Menopause Society. We have a patient-facing arm, Women's Health Concern, and we have lots of valuable resources for patients there. Obviously, I worked with Karger on Fast Facts, and that was updated, which I think is important. And the feedback from patients has been very positive. So I think, education for patients, education for providers of menopause care, which will largely be general practitioners. And I feel that women are entitled to good quality menopause care as part of the NHS. This ideally would be provided by GPs. And only those more complicated women that I touched on before, the women who've had cancer, or also women who have premature ovarian insufficiency, previously known as premature menopause. I think those particular patients are best managed as part of a multidisciplinary team. And I just think one of the most important things about menopause care is collaboration. So we collaborate with haematologists and in regard to venous thromboembolism, blood clots in the leg and the lung. I work very closely with the gynae oncologists and with the breast cancer teams, and I think that is important so that every decision that's made about care is informed and it's not taken without discussion and considerable thought.